good morning, everybody. Well, morning for me. Today, yeah, we're gonna be talking about one of my favorite topics in medical physics and in radiation oncology, which is QA in your clinic. Okay, so let's get started and jump into this. So the first thing that I wanted to provide was just a list of very excellent references that outline some recommendations for how to start developing a comprehensive quality control program in your clinic. It's not a comprehensive list, but these are some of what I think are the best documents for getting you started. And of course, you'll get the slide deck, so you'll be able to go ahead and reference these documents on your own. I highly recommend this first one, Safety is No Accident. It's a really fantastic document. It's really accessible. And a lot of my lecture today is going to be kind of pulled from that document and condensed for you. So definitely go and download that as soon as you can. Today, our learning objectives are first to be able to describe the components of a comprehensive quality assurance program, to describe the details and the importance of each component of a QA program, and to explain the benefits of implementing a comprehensive QA program in your own clinic. There are several goals of QA programs, the first of which is to improve your work practices, to monitor risk and the things that might lead to incidents in your clinic, to prevent those major accidents from occurring, to encourage vigilance among all staff members in the clinic, and to practice incident learning. And we'll talk a little bit more about what that means a little bit later. So I wanted to start this presentation by giving a few examples of famous errors in radiation oncology, just to sort of set the stage for the things that can happen when we're not being vigilant about our practices. The first incident occurred in Glasgow in Scotland in 2005, and it involved a teenager named Lisa Norris. And she was being treated for pineoblastoma using craniospinal radiotherapy, which is, of course, a very complicated technique. Before her treatment, the clinic had recently upgraded their treatment planning system, and this led to major workflow changes in their clinic. And so previously, most of their workflow or all of their workflows utilized paper forms, and the new system upgraded them to using electronic calculations and reporting, though they still retain the paper forms for complicated treatments like whole CNS. In the case of Lisa Norris, an inexperienced planner picked up her case, and they were unfamiliar with the new features of the system. So what happened was they incorrectly imported the prescription data in the wrong format, and this resulted in an incorrect calculation and output factor for the head fields. So Miss Norris was supposed to receive 35 gray and 20 fractions, but instead she received 55.5 gray in 19 fractions before the error actually was caught. And as a result of this severe overdose, she passed away in 2006. The error was actually caught because the same dosimetrist made the same mistake again for another patient, but this time realized the error. And when the error was evaluated for root cause, ultimately, the primary contributing factors were determined to be that because the planner was so inexperienced, and there was also an observation bias nature of the clinic's plan check process. So that failed to identify the error. A second famous error occurred in Epinal, France in 2004. And in this clinic, they were transitioning from using hard wedges to dynamic wedges, and an error was introduced into the treatment planning system. So instead of calculating the MUs for the dynamic wedge, the MUs were still being calculated using the hard wedge settings. So the problem was then identified when the software was later upgraded. But as a result, 5 people died, 20 were severely injured, and approximately 5,000 other patients were mistreated due to this and additional errors. In 2007, the department was actually temporarily shut down, and 2 doctors and the physicist stood trial and were actually sent to jail because they tried to cover up this error. And when the error was analyzed for root cause, it was determined that the primary contributing factors were that the staff had little preparation and training for the upgrade. And a second issue was actually that the manual had not been translated from English into French. And so there was misunderstanding of how the system operated. And then finally, there was no independent dosimetry check to ensure that the MUs for the dynamic wedge made sense. Of course, you're going to be delivering much higher number of MUs for a hard wedge to account for that transmission than you would for a dynamic wedge. So one of the things that when I was a very young physicist, one of my mentors told me was when a radiation oncologist makes a mistake, they mistreat one patient, but when a physicist makes a mistake, you mistreat the whole clinic. And I think this is really a great example of how vigilant we have to be, especially as physicists, to ensure that when we make transitions and when we commission systems, that we are very careful and put many, many checks into the process to ensure that everything that we're doing is accurate. So then finally, the take-home message of this is that times of transition require special attention. And all of you are going through a time of major transition. And so I really encourage you to kind of soak in everything that I'm going to talk about and really develop your commissioning plan in a way that gives many different angles of checking and double checking and triple checking before implementing this into your clinic. So there's a model for quality control called the Swiss cheese model, and it was originally designed by a man named James Reason in order to eliminate errors in the oil industry. It was later adopted by the airline industry, but there are so many ways that it's extremely applicable to the medical industry as well. You can imagine that the slices of the Swiss cheese are barriers, like you can see here, but Swiss cheese has holes in it. And so the barriers will block between hazards, which are mistakes that can happen, or like latent conditions in your clinic that could lead to an injury or something else. And then the barriers block from these hazards to result in losses, which, yeah, would be an injury, death, not even necessarily something that, dramatic, but like a process inefficiency would even be considered a loss in this model. So every barrier is not perfect. It has holes. And so sometimes your barriers, which can represent different checks in your workflow, sometimes an error slips through one of those holes. But the ideal design of your barriers, of your quality control program, is that at each stage of medical care, you may have one or more barriers. And each of those barriers, which might be procedures like checklists or timeouts. They might be alarms, physical barriers, interlocks, those types of things. Or it could be like an overarching kind of administrative control of that workflow. And so each of those barriers should be designed ideally so that if an error slips through one hole, it gets stopped by another barrier. So this situation where you have a hazard drawing a straight line through the holes in all of the barriers is like this indicates that there's poor design in these barriers, and probably another checkpoint should be inserted at some point in this process to block this error from coming through. So yeah, we want to ensure that it's very difficult to make this straight line through the barriers. And if you do have a hazard that results in a loss, we'll talk about a little bit later what sort of process we can use in order to identify the weaknesses in these barriers and how to improve them. So that is our moral of this slide. All right, so this is kind of a complicated slide, and I encourage you to kind of look back at it in your own time. But this is a diagram of what a QA program, I shouldn't say should, but might look like. So a good way to develop your QA program is to map out the process that you're using. So that would be our radiation oncology process, basically that goes from the physician order all the way through the treatment and the completion of therapy. And the idea is that you would map out your process, and at each point in the process, think about all of the potential hazards or the potential errors that could occur at each point in that process. So, for example, at simulation, we might have the wrong setup or orientation. We might be planning for the wrong modality. The setup accessories might be inappropriate for the patient. The scan range might not be long enough. You might cut off some of the patient anatomy that you need. Image transfer might not work correctly. The skin markers for your alignment might not be placed correctly. So all of these things and more are things that could go wrong at simulation that could result in an error at some point. So we do that for every point in the process. And then for every hazard, we want to come up with some sort of quality assurance check, which is shown in this level, that could possibly catch and eliminate these errors before we make it to the next stage in the process. So for example, one of the most complex steps in our process is, of course, the planning step. And therefore, because it's the most complex, it's also the most vulnerable to errors. So creating a safe plan in accordance with the physician's intent is the responsibility really of the dosimetrist, the physician, and physics. It's not just the dosimetrist's responsibility. So for every potential hazard associated with planning, we should create a quality assurance check. This could include, for example, a check of all contours, which would catch errors like an incorrect normal contour, an incorrect target, incorrect margins. So that would eliminate, or that should be able to eliminate 3 errors off of this list. And a second example would be that we would have a chart round session. So chart rounds or peer review would have, another physician, probably another physicist in the room reviewing the plans, and they could catch other things like the wrong dose being applied to the plan, the wrong modality being used. If the doctor intended to use electrons, but instead it was planned with photons, we could catch that in a peer review. And maybe the plan is still appropriate, even if it did use the wrong modality, but then we have to go back and revise the intent. You could also catch suboptimal plan quality in a plan review. So, and then the third check in this case is a secondary dose calculation, which of course would catch the wrong dose computation parameters being implemented. So that's a very important calculation, as we learned from the story in Epinal. So basically the quality of a good QA process is to be able to predict errors that might occur at each step in the process, and then insert checkpoints in order to minimize the occurrence of these errors. So peer review. One very important thing to remember is that QA is everybody's responsibility. It's not just a physics task. Every team member in the clinic should know his or her responsibilities. They should be trained to perform them, and they should know what actions are to be taken if a test or a check fails. So this table I pulled out of that document, Safety is No Accident. It kind of outlines the team members on this column, examples of peer review that the team member might participate in, and some examples of quality assurance that that same team member might participate in. So the physician, for example, you might go into a peer review and they would verify that they agree with the target definition, the dose selection is appropriate for the pathology, and the technique is appropriate for that type of pathology as well. But quality assurance that they might do is that they'd verify that all of the nomenclature of the documentations is appropriate for the clinic standards. They would verify that their dose constraints are all met by the plan. And they also review portal films on a daily basis to ensure that the patient is setting up correctly. So I guess one of the really important things to remember is that this whole system, especially this slide, the previous slide, might look very overwhelming to you. And it might seem like everything that I'm saying is completely impossible for you to implement in your clinic with your given resources. And that's totally okay. A detailed QA program is what we as a field are striving for. And even in most clinics across North America, including my own, we haven't yet achieved the most ideal level of quality control. The very most important thing is that you are always taking small steps toward achieving these goals and constantly evaluating your program to find the weaknesses of that program and how you can move towards strengthening these weaknesses. Okay, so our first poll question. What is the function of the different slices in the Swiss cheese model for quality control? Is it A, slices represent checkpoints in a process? B, slices should be designed to ensure that, that single errors does not result in a process failure? C, slices can represent procedures, checklists, physical barriers, or machine interlocks, or D, all of the above.
I went ahead and launched the poll, so feel free to answer and we'll give everyone another minute to respond. Okay, go ahead and get those last few responses in and we'll go ahead and wrap up that poll.
Looks like we got answers from everybody. And most people did say D, all of the above, which is absolutely correct. So all of these things are true about the Swiss cheese model for quality control.
Real quick, before you continue on, Tia, we did have a good question from the chat wanting to address the importance of the setup session or a dry run. So is it preferable to conduct this session without delivering dose to the patient to ensure that all of our treatment parameters are correct before starting the treatment?
So by a dry run, I'm assuming that you mean a VSIM, a verification simulation at the treatment machine. This is a recommended practice, mostly for the physician to verify that the ISO center, the setup is correct. I think that, so besides a dry run, many people are also going to be running like a QA measurement, which would be before the patient gets on the table, and that is also a recommended process. Certainly for 2D or 3D treatments, we should at least be doing a hand calculation, a verification calculation to make sure that the MUs are accurate. If you have the resources to perform a measurement, that's great. But yes, we typically want to do a verification simulation so that the physician can make sure in advance of delivering dose that the patient is setting up correctly.
Great, thank you.
Okay. So this next slide talks about one of my personal favorite concepts in the clinic, which is safety culture. And this is a concept that we really hope to manifest in our clinical practice. And having a positive safety culture has been shown through pretty solid data that it really improves the quality of care, and it significantly reduces the number of errors that occur in a clinic. The fundamental idea of safety culture is that we want to create a positive environment in which all staff feel comfortable and encouraged to report all safety events without the fear of punitive actions, whether or not the event results in harm. And some of the key aspects of a positive safety culture are going to be indicated in this nice, colorful diagram here. Safety culture should promote a culture of transparency in which everyone in the clinic is mobilized and understands their role in promoting safety. All team members should share an awareness of the most significant risks in the clinic, and they should maintain a questioning attitude so that if something seems incorrect, they feel comfortable to speak up, which could potentially prevent an error from occurring. In order to foster a positive safety culture, it's important to have really clear policies, and they should all be very formally written and clear and concise so that they can be accessed by all individuals in the clinic. And they should include the roles and responsibilities of each individual, each team of individuals. It should include clinical procedures and protocols. It ideally will include information about radiation safety in your clinic, all emergency procedures for the clinic, and usually also for your hospital institution as a whole. And it should have information about all the national regulations and licenses that are required for meeting the requirements of your state or country. These policies should be reviewed annually to ensure that everything has been updated as procedures have changed. And of course, if it's most ideal to update the procedures like as soon as they change, or like within a timely manner of those processes that changed. And again, these are goals that we strive for and we develop over time as we continually improve our clinics. This isn't something that needs to exist immediately. Okay, so now we're going to talk about incident learning. So although we do our best to predict errors before they happen, it's inevitable that sometimes an error is going to slip through the holes in our Swiss cheese, and it's going to make it far down the process, or it might even make it to the patient. And when this does happen, it's really important to evaluate how and why it happened, and to determine the best and most efficient way to ensure that it's not going to happen again. Per our safety culture discussion, the goal is not to find the person to blame for the event, but to find the hole in the process that allowed the event to occur. And this process by which we do this is called incident learning. Good incident learning practices utilize a centralized system to report all incidents. These might be reported as one of several categories, including events that reach the patient with or without harm, events that don't reach the patient, which are also called near misses, unsafe conditions in the clinic, or operational process improvements. So these events should be reviewed regularly and studied, and what's learned from them should be disseminated to the rest of the team. Incident learning can also be multi-institutional. For example, there's a system in the US called Royals, and it's a national incident learning system. The goal of Royals is to facilitate higher care in radiation oncology by providing a centralized mechanism for sharing and learning in a secure and non-punitive environment. So all clinics can sign up voluntarily and they can submit data. All of that data is completely anonymous. And it's actually, there's a law protecting the use of that data to like come at a clinic for issues. All data that's submitted is completely protected. So the idea is that, we want to be able to collect this data so that we can learn from each other to improve our own clinic practices. So the next question that you might have is who should be responsible for consolidating and evaluating the incidents in your clinic? And this task is typically delegated to a quality assurance committee who develop feasible initiatives related to patient safety. The QA committee ensures that there are mechanisms for reporting, mechanisms for implementing change, and reviewing and analyzing all reported events as they accumulate. The committee will also monitor the appropriate compliance with local and national safety licensure and credentialing. And they must have access to all of the resources that they need in order to initiate and support a QA process and disseminate safety information to all staff. So in my clinic, we have a monthly meeting for all of the events that we've submitted to Royals. It's most of the clinic participates in this meeting. And we will go through that list item by item and present each item and talk as a group about why we think that event happened and what can we do to implement a change in order to make sure that it doesn't happen again. So some of these incidents can be resolved really quickly. Some of them are like, oh, that was like just a weird one-off, like it's probably not going to happen again. Some of them are like easy solutions that we can basically implement nearly immediately. And others are more process related and are much more complicated to solve. And so those get sent to a different meeting, which is called process improvement, which is a second group of people, a much smaller group of people who analyzes each of these more complicated events and then assigns a team of people to work on changing the process to find a solution to make our clinic more safe. And we find that this works extremely well. We go from error to process improvement very rapidly. And so it's really cool to see that actually emerge in our clinic. All right, so here's our second question. A physicist performing a treatment approval check notices that the patient has a pacemaker that was not documented and taken into consideration for planning. What should the physicist do? A, correct the error and continue checking the chart. B, identify the person who forgot to document the pacemaker and report this person to the clinic manager. C, correct the error and record it in the clinic's incident learning system for discussion at the next safety rounds. Or D, identify the person who forgot to document the pacemaker and confront them directly.
Okay, everyone, I've gone ahead and launched the next poll. Feel free to answer and we'll wrap it up. All right, we'll go ahead and wrap up that poll.
All right, so very good. Most people said C, correct the error and record it in the clinic's incident learning system for discussion at the next safety rounds. This is absolutely correct. The whole idea of promoting a positive safety culture is that people who make errors should be treated like there's no punitive action. So people who make errors should not get in trouble for making those errors. So maybe it is actually appropriate to mention to that person who initially forgot to record the pacemaker that, hey, this pacemaker didn't get recorded. No big deal, but just be aware for next time that we want to just make sure that those get written down. I'm sure it was just you had a busy day and it just got missed, because every person makes mistakes. But really, it probably wasn't just that one person who forgot to write down that the patient had a pacemaker. There was probably several other steps along the way. So for example, that person probably got a CT scan and the dosimetrist planning that patient maybe didn't scan through the whole scan and notice that there was a pacemaker in there. And maybe the physician did not document that the patient had a pacemaker, which would have, helped the simulation therapist realize that the patient had a pacemaker. So there are a lot of people along that path who also missed that detail, it wasn't just a single person. And so what we really want to do is we want to record that in our incident learning system and then discuss as a group, how do we make sure that we don't miss pacemakers next time? So very good, everybody. All right, the next portion of my presentation is going to have a little bit more of a physicist heavy component, but it's still very important for all staff members in the clinic to have a good sense of these concepts. And so I really, although it's, very important for the physicist to understand this, it's also really useful for other members of the team to understand the types of things that a physicist is thinking about as they're developing quality assurance programs. So quality assurance is a team effort, but as the technical expert of the team, the physicist should expect to take a leadership role in the technical aspects of the treatment in order to maintain quality of care and safety. Information flow is a very complex process in radiotherapy, and so the accuracy of all the information that's transmitted has to be ensured. So in order to do this, it requires technical expertise in each step of the process. And so this is everything from the operation of the machine, planning and dosimetry. A physicist really needs to know how to plan well in order to ensure that the plans that they're checking are of the highest quality. They should understand the way that the dose is calculated within the treatment planning system, because this can really this can really help you to detect some errors in the treatment planning system. It can also help to troubleshoot problems that the dosimetrist might be having with something. So that technical aspect is important as well. And the physicist should also understand the details of the data transfer to the machine, because as you're transferring a plan to a machine, corruptions of data can happen. And by understanding how the data gets transferred and how the machine interprets that data, it can also help troubleshoot problems. So information flow also requires very careful and complete documentation of all QA that occurs. All QA forms should be simple and easy to follow, and they should all be kept in one place, whether this is a paper binder or an electronic location. It's really important that everything is in one place that is not locked down so that it's accessible to everyone who needs it. One of my colleagues actually worked as a consultant in a clinic several years ago, and the physicist who had previously been at that clinic went out on medical leave somewhat urgently. And so she came in and took over the clinic and discovered when she did her calibration procedure that the machine had previously been calibrated and was running 8% hot. And normally our tolerance is about 2%. And so it was a bit alarming. And when she went to look for the QA records, all of those records were stored on a locked disk on the previous physicist's computer, and she had no way to access any of the history. And so that made it really a lot harder for her to figure out like how long it's been like this, like how did the error happen in the first place. And so anytime, you might have new physicists coming in, you might have auditors coming in, you want all of your QA to be in a place where everyone can get to it easily. As far as QA goes, the amount and the types of QA that you perform should really depend on your clinical objectives as well as the resources that you have available for QA. There's two levels of tolerance and action levels. So there's two levels of places where things need to be evaluated. A tolerance level is the level at which the acceptable deviation is fine. There's a risk of harm, but it's moderate, and a change in the process or an adjustment is recommended, but not obligatory. And an action level is the deviation above which the risk of harm is high, and a change in the process or an adjustment is obligatory before a treatment can continue. So an example of this is that you probably run a daily QA where you check your outputs. And when you run your morning outputs, typically we define the acceptable deviation at two levels. The tolerance level would be the deviation at which it's acceptable to treat, but the physicist should be notified in order to investigate later. So most clinics will use 3% for their tolerance level. And this would be the point at which, it's safe to be treating a patient with this level of deviation. But when there's time for the physicist to look at the machine, they should evaluate why it got to be this high and make an adjustment to make sure that the beam is calibrated correctly. The action level would be the level at which the output deviation was large enough that it would significantly affect the intended dose to the patient. And so treatment has to be terminated immediately, and a physicist should be notified to address the issue immediately. And most clinics use a 5% deviation as this action level.
Tia, real quick,
Yes.
I have had a quick question. What is the difference between quality assurance and a quality check in radiotherapy?
So I would say that they're probably the same thing. There's a slight distinction between quality assurance and quality control. So quality control would be sort of the overarching system that defines how like quality yeah, it's more about the overarching system as opposed to like the individual checks, whereas quality assurance is ensuring that everything that we have defined as being the baseline is still at that level. So we're doing individual tests in order to make sure that the machine is operating at its current level, or that the plan has been developed to be the optimal quality. So yeah, I would say I would say a QA check, a quality check is equivalent to a QA task.
Okay, thank you for the clarification.
So when we define action levels, they should be quantitative and they should reflect the required outcome. So above this level, it is unsafe to treat. Below this level, it is safe to treat, but maybe we need to do something. And they should also be informed by the achievable outcome. So if you set your action level too tight, it can't be realistically achieved and you'd never treat. But if it's too loose, it won't be able to identify any unsatisfactory practice. So for example, if you have if you have a machine that frequently has a 3% deviation from the calibration level, you don't want to set your action level at 3% because it's normal to see that on your machine. However, if you have a machine that's always within 1% of your calibrated dose, setting your action level at 3% setting your action level at 5% might be completely unreasonable, because if it deviates from 1% by that much, that would be completely crazy. Like maybe an action level of 3% is more appropriate, because it would indicate that something was different about the performance of the machine. And very importantly, your action level has to be unambiguous. Like everyone should understand, above this number, we do not treat. Below this number, we're okay to treat. Should be easy to understand. And as your practice improves, you can change these levels. You can tighten them if your practice is improving and you're finding that you're not exceeding your action level as frequently as maybe you used to. Yeah, that's all I wanted to say there. So there are many documents out there that provide recommendations about how frequently tests should be performed on your machines, on your TPS, and your patient charts. But as tests become less frequent, they also should become more detailed, and typically they are more time consuming. And although in a perfect world, we would follow every recommendation to the letter, the differences in our available resources often make this impossible. For example, I used to work as a solo physicist at a clinic with very limited resources. My clinic had a sister clinic that had a lot more resources. At the sister clinic, they would, for every plan that came through, they would perform a secondary dose calculation, an ion chamber measurement, and a map check measurement for every IMRT patient. However, they had a staff of 6 people to help perform these measurements. At my clinic, because we were a much smaller team and I was basically the only technical staff member, I was responsible for all IMRT patient QA, actually, as well as the planning. And I needed to balance this responsibility with all of my other responsibilities as a physicist. Ion chamber measurements are time consuming, and I did not have the resources to invest in something like that. So I would only perform the map check measurement because it provides the most information in the most efficient way. And I felt comfortable doing this because I'd set up a redundant system and careful QA practices that helped to ensure that my map check measurement was a good measurement. So instead of using an ion chamber every single month or every single patient, I would QA my map check device every month with an ion chamber to make sure that the map check device was performing up to my required accuracy. A very useful tool for QA is trend tracking. It's a practice that has the ability to substantially reduce the burden of QA testing and save you time, as well as improve the efficiency of your clinic. Trend tracking it's an easy way to interpret how stable a test is over time. And for example, you can see how your outputs vary from day to day in order to identify whether the machine is experiencing a normal drift or if there's some weird, unusual machine behavior. And it also informs you on how frequently a test needs to be performed. So, for example, if you have been testing the couch position accuracy once a month for 2 years and it has never failed the test, maybe it's reasonable to reduce the frequency of that test to once every quarter or maybe twice a year. Your testing frequency should also be informed by the severity of the result of it failing and not knowing it failed. So again, with the couch example, if you've been testing your absolute positional accuracy for like every month for 2 years and it's never failed, and you don't ever use the absolute couch position, you only ever care about relative couch position, then it probably is perfectly safe to reduce the frequency of that test because you're not really even using that information in your day-to-day practice. However, if you used the absolute couch position as the reference point to set up every single patient and that failed, then the result would be that every patient that you treated since that actually failed has potentially been mistreated. So you have to consider how the QA test is relevant to your clinical practice. That's very, very important. So this is an example, just a quick example of what trend tracking can look like. So on the left, we've got daily outputs, and on the right, we have monthly outputs. And you can really get a lot of information out of these graphs. So on the daily plot, you can actually see these discontinuities in the curves. At this point, we replaced an ion chamber, and because ion chambers tend to drift a lot faster when they're new due to the burn-in effect, you see that the slope changes. So the outputs are increasing much more rapidly than they were previously on an older ion chamber. At this point, we adjusted the outputs to get them closer to 0. They drifted again. And here we adjusted the outputs again. Another interesting thing that I want to point out is that for each output adjustment, you see the colors separate. So each of these colors represents a different energy. And so this kind of shows the variation and the uncertainty of adjusting your outputs in like solid water, a monthly setup in solid water, as opposed to a precise setup like TG51. So at this point, we did a TG51, so our annual calibration, and now all of our energy curves kind of lie right on top of each other again. And then at this point, you can see that the slope kind of levels out. And so that shows us where the end of our like burn-in of our chamber sort of occurred. So that's all information that we can get out of this one little graph. And then the other useful thing is that we can look at our monthly outputs, which are taken using a different setup and different device, and we can see that they follow exactly the same trend as the daily outputs. And so that's a great little sanity check when you're dealing with something as important as machine outputs.
Tia, we had a quick comment or concern from Sumi. Would using trend tracking to reduce frequency of tests not potentially lead to complacency?
So that's a very interesting question. I think that, you know, there's a fine line between like so my opinion is no, but I understand that there would be concern about that. The trade-off, I guess, with trend tracking is that yes, you might be able to reduce the frequency of your tests, but it requires a lot more vigilance in actually evaluating like what's going on with your trends. So it usually will require that instead of making a bunch of redundant measurements with different tools, it will require a very careful evaluation of the history of your tests and then very careful evaluation of how you want to set your tolerance levels in order to ensure that anytime anything deviates from normal, you're looking into that. So it's just kind of a different way of doing QA, but it definitely requires more vigilance in terms of looking at the data on a day-to-day basis in order to ensure that things are not deviating from the norm, as opposed to just making a lot of redundant measurements, if that helps.
Yeah, I think that's an important point to clarify. Thank you.
Okay. So there are a lot of platforms out there. They're considered unified platforms for your QA that can help facilitate trend tracking. These are just a couple that I could think of off the top of my head, and it's probably not a complete list of all of the options. So we've got, yeah, like Rad Machine is Radformation's solution, IBA MyQA, Sun Nuclear SunCheck, and then my personal favorite is ImageOwl Total QA. And the reason why I like this particular software is because it is fully agnostic to vendors. You can implement any of the devices that you already have in your clinic without having to purchase like all of the Sun Nuclear devices or all of the IBA devices. So that makes it so that you can really have a lot of flexibility and use the things that you already have. It also allows you to like completely customize the tests that you do customize the tests that you currently do for your QA into the system. And so even if you have a manual test that you do, you can build that test into Total QA exactly how you want it. So for example, like my clinic, we use like literally a sheet of graph paper to check our jaws and our couch movement. And so we were able to just build in a test, a pass-fail test or a numerical test to be able to just use our graph paper in Total QA. Another really great benefit of this software is that it's fully web-based and it requires absolutely no IT support. Basically, anyone who can download a file can do it. There's really nothing to it, and that's a big deal because I know in my clinic, getting in touch with IT is impossible, and a lot of people have that same experience. Okay, so we're coming to the end here. Key takeaways from this presentation are that times of transition require more attention than other times. Well, we always require attention, but times of transition, we require extra special attention. We want to build our QA processes so that a single error does not result in serious effects. We do this by predicting errors and inserting checkpoints at different points in our process in order to minimize the occurrence of errors. And of course, QA is everybody's responsibility. It is important to recognize that QA does require resources, and these resources are limited in many of our clinics. And so sometimes we have to make arguments for why we need certain things. So QA requires time. It requires, commissioning QA, writing reports, having meetings, training staff. It requires people, employees, dedicated staff with all the appropriate qualifications. It requires equipment. You need to have the appropriate instruments, phantom software in order to do good QA. So it's really important to be able to justify all of these resources. And in the end, we really achieve a lot of net benefit from investing in these resources. The benefits of good quality assurance can offset initial costs because these benefits include better patient care and better patient satisfaction, improved communication and efficiency of our workflows, which in turn increases our throughput in our clinic. We literally could be able to treat more patients. It improves the safety for our patients and our staff. And it results in less waste, since when you make fewer mistakes, that means that less work needs redone. So really, like the small investment up front results in just so much benefit for your clinic. All right, and we got one more question here. Who is responsible for QA in the clinic? Is it A, the physicist, B, the radiation oncologist, C, the therapist, or D, all of the above?
Gone ahead and launched that last sync poll. All right, I'll give it a couple more seconds. All right, here are the results.
All right, most people got it correct. It is D, all of the above. So remember, we talked about safety culture, and everybody in the clinic needs to be mobilized. Everyone needs to know their role, and everybody participates in quality assurance of our work processes. So although physicists do maintain the QA of our equipment, our machines, they manage a lot of the quality control in the clinic, and typically are the ones who are doing our process improvement. Every individual in the clinic has a role in quality assurance. So at this point, hopefully you can describe the components of a comprehensive quality assurance program, describe the details and the importance of each component of that quality assurance program, and explain the benefits of implementing a comprehensive quality assurance program in your clinic. And then again, I wanted to make another plug for this reference, Safety is No Accident. Many of the slides here did pull information directly from this document. It is so accessible. It really outlines every individual's role in the clinic in safety and quality control, and it gives really nice suggestions and guidelines for you to start thinking about how to implement a framework for quality control in your own clinic. This is just like little pictures. This is my clinic. This is actually the view from the parking garage at my clinic. And interestingly enough, our clinic was we had a lot of women working as radiation oncologists and physicists in our department, which is kind of cool. And we went to a play called The Half-Life of Marie Curie as a girls' night. And that's our picture of our physicists and our radiation oncologists.
Wonderful. Thank you. Thank you so much, Tia. I feel like this was such an amazing presentation, and really these slides are going to be a wealth of resources for anyone looking to start a QA program.